Welcome to APMA Online CECH. I'm Dr. Diane Tower, APMA's Director of Clinical Affairs, and I'll be your moderator today. APMA is pleased to offer its members 3 continuing education contact hours, or CECH, total over a 5-week period on a variety of topics. These live webinars will be recorded and are provided complimentary exclusively for APMA members. This is week 1 of the series, and we are going to hear about issues impacting your practice and patients during the COVID-19 public health crisis. APMA has approved this activity for 0.5 continuing education contact hours. No commercial interest provided financial support for this continuing education activity. We will have a few minutes at the end of today's webinar to address questions, so if you have any questions throughout the presentation, please type them in the questions box in the GoToWebinar toolbar. We will address as many questions as we can in our allotted time and apologize in advance if we can't get to all of them. I want to introduce our speakers and let them get right into the presentation. To start, we have Benjamin Wallner, APMA Director, Legislative Advocacy and APMA PAC, with a legislative update. Mr. Wallner has no relevant financial relationships to disclose. Dr. Jeffrey Lehrman, APMA Coding Consultant, will follow with a telemedicine update. Dr. Lehrman has disclosed the following potential conflicts of interest: consultant for the American Podiatric Medical Association and principal for Lehrman Consulting, LLC. And Chad Apple, APMA Director for the Center for Professional Advocacy and Associate Director, Health Policy and Practice, will close out today's presentation with a regulatory and scope of practice update. Mr. Apple has no relevant financial relationships to disclose. I will hand it over to Ben.
Thank you, Dr. Tower. My name is Ben Wallner. I'm going to give you an update on the most recent legislative packages that have been passed by Congress, and then I'm going to talk briefly on our efforts to engage Congress on future packages. So starting out, next slide, please. The first package, on March 6th, President Trump signed into law the first COVID-19 related bill, the Coronavirus Preparedness and Response Supplemental Appropriations Act. This bill provided $7.9 billion for the initial public health response to the pandemic. This included $6.5 billion for the Department of Health and Human Services for health emergency prevention, preparedness, and response activities related to COVID-19, which includes approximately $3.4 billion for the Public Health and Social Services Emergency Fund, $2.8 billion for the Centers for Disease Control and Prevention, and $897 million for the Food and Drug Administration and the National Institutes of Health. Next slide, please. The Families First Coronavirus Response Act, HR 6021, was signed into law by President Trump on March 19th. This was the second package. The bill primarily focused on providing access to COVID-19 tests, expanded unemployment benefits, and expanded Family Medical Leave Act and sick leave, including business tax credits for the expanded leave. Specifically, the bill guarantees free coronavirus testing to anyone who has doctor approval for the test. It provides for new refundable business tax credits for certain mandated employer-provided paid sick leave and paid family and medical leave, provides $1 billion to states for expanded unemployment compensation and food assistance, and mandates 2 weeks up to 10 days of paid sick leave for most employees and 3 months of paid emergency family and medical leave, covering at least 2/3 of an employee's wages throughout the coronavirus crisis. Next slide. On March 27th, the President signed into law the third coronavirus package, the Coronavirus Aid, Relief, and Economic Securities Act, known as the CARES Act. This bill was approximately $2 trillion in tax and spend, intended to address the effects of the COVID-19 pandemic in the U.S. Major highlights from this legislation include $349 billion for the Small Business Administration's Paycheck Protection Program, $10 billion for SBA's Economic Injury Disaster Loan Program, EIDL, and $500 billion for the Federal Reserve for lending and liquidity purposes. The act includes $260 billion for increased unemployment assistance, including up to 4 months of full replacement wages up to certain limits for individuals who lose a job or are furloughed due to the coronavirus crisis. The bill also provided $1,200 for singles, $2,400 for married couples in the form of a tax rebate for all U.S. residents with incomes up to $75,000 for individuals, $150,000 for married couples, eligible for up to the full $1,200 in a rebate. In addition, they are also eligible for an additional $500 per child. More specifically, the issues of importance to physicians and other healthcare providers. HHS Provider Relief Fund received $100 billion in funds for hospitals and other healthcare providers on the front lines of the coronavirus response. This funding will be used to support healthcare-related expenses or lost revenue attributable to COVID-19. These funds are payments, not loans. $50 billion of the Provider Relief Fund is allocated for general distribution to Medicare facilities and providers impacted by COVID-19 based on eligible providers' 2018 net patient revenue. The initial $30 billion was distributed between April 10th and April 17th. All facilities and providers that received Medicare fee-for-service reimbursements in 2019 are eligible for this initial rapid distribution. The remaining $20 billion is being distributed to Medicare Advantage and Medicaid providers beginning Friday, April 24th. Providers who have received funds must sign the attestation form. The remaining $50 billion will be distributed through targeted accounts focusing on uninsured patients, COVID-19 hotspots, rural providers, and the Indian Health Service. The bill also included a Medicare sequester relief through the end of 2020. Next slide, please. On April 24th, President Trump signed into law the Paycheck Protection Program and Healthcare Enhancement Act, known colloquially in DC as COVID 3.5. The bill provides $484 billion in additional funding to replenish and supplement key programs under the CARES Act, including the Paycheck Protection Program, small business disaster loans and grants, hospitals, and healthcare providers and testing. $75 billion was included for the Department of Health and Human Services Provider Relief Fund to support the need for COVID-19 related expenses and lost revenue due to coronavirus. $321 billion in funding for the Paycheck Protection Program, with $60 billion set aside for small, mid-sized, and community lenders, and $50 billion for the Disaster Loan Program, and an additional $10 billion for the EIDL grants. Next slide. Lastly, as we look to future legislation, APMA is actively engaged in advocating for increased supplies and access to personal protective equipment, more testing for providers, hazard pay for frontline workers, support for rural facilities that may have been left out of the first 2 rounds of relief, expanded access to and fair reimbursement for telehealth services. There is some talk that the next package may also include regulatory relief, so we focused our efforts on requesting relief within the same and similar program on reduced reasonable use lifetime for durable medical equipment. We've requested that they not apply the same and similar program for acute conditions, for replacement of off-the-shelf devices after 90 days, for custom devices that are replacing an off-the-shelf device. We've sought relief to suspend appropriate use criteria for advanced diagnostic imaging services and or delay the implementation of the criteria, which was set to go into effect on January 1. We are requesting an extension of the suspension of sequestration through 2021 to maintain the current telehealth allowances beyond the current emergency, eliminate the certification requirement in Medicare Therapeutic Shoe Program for persons with diabetes, and require Medicare Advantage organizations and plans to state the reason for all medical records requests, If the reason is something other than coverage decision-making or resolving an appeal, then require the Medicare Advantage organization to pay for the requested records, establish reasonable maximums for document requests, and if those plans choose to pay providers based on Medicare fee-for-service rates, then we ask that they be required to comply with coding and payment guidance of LCDs and NCDs, such that the claims would be adjudicated in the same manner as fee-for-service. Lastly, that all providers would auto-qualify for MIPS extreme and uncontrollable circumstances for 2020 or shorten the MIPS 2020 reporting period. This concludes my review of recent and future legislation, and with that, I turn it over to Dr. Lehrman.
Thanks, Ben. Each of us, Chad, Ben, and I in this presentation are covering some tools that can help us survive this COVID-19 public health emergency. And on the next slide, one of those tools is our ability to provide non-face-to-face services during our patients throughout this COVID-19 public health emergency. Doing this allows us to remain engaged with our patients, to continue to care for our patients, those that we think it's not appropriate for them to come into the office. Also helps us to serve and protect our community by keeping people at home who we can keep at home and protect them, protect our staffs, and protect the rest of the community. This slide has some important words on it, and the terminology here is important because one of the errors that we're seeing people make is not understanding which of these terms means what. And to take a step back, it's important to understand there are several different types of non-face-to-face services. So we can't apply the same rules to all of these. And the umbrella term, what you see on the left part of this slide, is non-face-to-face services. That's actually the title in the CPT book. And then there's a whole bunch of different types of non-face-to-face services. And they all have different rules, different guidelines, different compliance things, different documentation requirements. So when we see a person who's not in the same room with us, that is a non-face-to-face service. And again, there are different non-face-to-face service types. First is telehealth. Now, Medicare's definition of telehealth is live, interactive, two-way audio and video, with the example given being FaceTime. I think we all know what FaceTime, right? So telehealth, by Medicare's definition, means live, interactive, two-way audio and video. Got to look like FaceTime or its equivalent. The Medicare virtual check-in is the next option. That's for Medicare patients only using a communication device other than live, interactive, two-way audio and video. Telephone is actually talking on the phone. And then the last one is online digital. That refers to digital communication. When you think digits, that's numbers and letters and characters. So text message is an example. Email is an example. If your EHR has a portal that allows for this type of communication. All four of these are options. On the next slide, we can talk about the HIPAA considerations that go along with this. HIPAA is not a Medicare thing. HIPAA is administered by the HHS Office of Civil Rights. So this applies to any insurance type. That Office of Civil Rights has told us that they will exercise enforcement discretion and waive penalties for HIPAA violations if we are providing these services in good faith. And again, they use FaceTime as an example. On the next slide, we can see that from a Medicare perspective, when all of these allowances and waivers were first announced, next slide, please. We were told that some of these we could only do for established patients, some of these we could only do for new patients, and it kind of got confusing. For Medicare, as of March 30, all four of these services are listed on the next slide. Medicare told us that we could provide any of these services for both new and established patients. So again, on March 30, Medicare made an announcement that was retroactive to March 1st that told us we could provide any of these services for both new and established patients. And Dr. Tower, if you could advance the slide, please. I mentioned that all 4 of these service types have different guidelines, different requirements, and all of those are listed at apma.org/EM remote. We listed the 4 different service types. Again, different requirements, different guidelines, different coding for each of the 4. This website is available to members, apma.org/EM remote, and it lists all those different types and what the different requirements are for each. Now, I was careful to say that we're referring to Medicare guidelines. Unfortunately, non-Medicare payers may not follow the Medicare guidelines. And in many cases, these private payers have their own guidelines, which might differ. Now, there's a link on this website to a bunch of the private payer policies so we can read what their policies are. Many of them are also allowing that first option of telehealth. So that's an overview of the non-face-to-face services we can provide, a website for where to go that explains all of this in great detail, all of the guidelines we need to provide these services, code for these services, and remain compliant in how we document our performance of these services. So that's one more tool that we can use during this time. My colleague in APMA's Health Policy and Practice Department, Chad Apple, has more tools and resources to help us survive this COVID-19 public health emergency. So we'll transition it to Chad to take us the rest of the way.
Great. Thank you very much, Dr. Lehrman. I want to first provide a brief update on state issues, and then we'll move on to regulatory updates. Next slide, please. Thank you very much. During the beginning of the COVID-19 pandemic, APMA heard from a lot of podiatrists who wanted to use their medical degree and experience to help during this public health crisis, including serving on the front lines of their hospital or helping alleviate their MD and DO colleagues' patient load. And to help our members, APMA issued a position statement supporting a temporary relaxation of state scope of practice laws during the length of the public health crisis. APMA worked with state component societies to reach out to their governors and state officials. APMA also, along with several other national podiatric organizations, sent a joint letter to the National Governors Association urging that our nation's governors temporarily relax scope of practice laws for podiatrists. And we have heard that a few states have responded and have relaxed scope of practice laws for all providers, including podiatrists. And others have responded that podiatrists can work on the front lines in their hospital if they work under or with a MD or DO. For questions about your specific state, we encourage you to contact your Board of Podiatry or your state Department of Public Health. Another question that's come up recently is whether podiatry offices are considered essential services. Now, some states just copy and pasted the U.S. Department of Homeland Security, Cybersecurity, and Infrastructure Agency's list of essential workforce. And the problem was, under that list, and under the healthcare category specifically, podiatry wasn't listed. While we believe some states assumed that DPMs were considered under the physician designation and thus essential, in other states, state societies sought clarification. And so to avoid confusion and to ensure podiatry offices are considered essential services across the country, APMA reached out to DHS and urged them to either issue a clarification or to update their list. Now, DHS did end up releasing an updated list that, while still doesn't include DPMs, it does say healthcare provider, including but not limited to, and then has a list of provider types. We haven't heard other issues from states since this has been released, but please let us know if your state doesn't consider podiatry essential service. In the meantime, Ben Wallner, who you heard from earlier in the webinar, is working with Congressman Wenstrup and others on the Hill to add some congressional pressure. Now, the next issue we are seeing is that some states are starting to open up and are putting together plans to allow hospitals and providers to begin elective surgeries. We are monitoring these activities closely. We encourage members to talk with their hospitals and ambulatory surgical centers. Next slide, please. So we go on to a regulatory update. Next slide, Dr. Tower, thank you. As Ben mentioned, Congress appropriated $175 billion to prevent, prepare for, and respond to coronavirus, and reimburse eligible healthcare providers for healthcare-related expenses or lost revenue attributable to coronavirus. To effectuate this law, as Ben mentioned, HHS distributed $30 billion to Medicare fee-for-service providers and facilities in direct proportion to their 2019 Medicare fee-for-service spending. Funds were distributed on April 17th and April 24th. HHS used Optum Bank, which is the United Healthcare Group. Providers roughly received about 6.2% of their 2019 Medicare fee-for-service amounts. Funds went directly to each organization's TIN that normally receives Medicare payments. Of that remaining $20 billion from the $15 billion general allocation that Ben mentioned earlier, approximately $10 billion was released on April 24th to mostly hospitals and other facilities. This is referred to as the second tranche. Other providers, including podiatrists, who were eligible to receive a portion of the $30 billion allocation can apply for a portion of the remaining $10 billion. You apply directly on HHS's website at hhs.gov/provider relief, and we'll show that link on the next slide. HHS has stated the total $50 billion general allocation is based proportionally on providers' 2018 net patient revenue, as Ben mentioned earlier. Thus, it is APMA's understanding that the total funds being provided in the second round will take into account any funds the provider previously received as part of the $30 billion distribution. Providers must attest to the terms and conditions within 30 days of receiving the funds. And even if you don't attest and you keep the money, HHS assumes you accept the funds in the terms and conditions. The terms and the conditions of the $30 billion and the $20 billion are almost identical. We encourage members to review the terms and conditions closely. And on this slide, we identified some issues to review closely. One question that we received a lot is whether these funds apply to providers they don't actually see or treat COVID-19 patients. In response to that question and other issues, APMA and other medical associations made an inquiry to HHS, and HHS updated the terms and conditions to clarify that offices that closed because of COVID-19 pandemic are eligible to receive the funds, and HHS takes a broad view that every patient could be a possible COVID-19 patient for purposes of providers being eligible for these funds. Finally, as Ben mentioned, HHS will be making targeted allocations and releasing more details soon. Next slide, please. And here you'll see the website to the provider relief funds, as well. You'll see the hotline if you have issues about refunds or questions, call that hotline. Again, you also reach out to APMA if you're having trouble with that hotline. And on the webpage is also APMA's updated resource. We have a webinar related to this, as well as FAQs and additional information. Next slide, please. While we are limited on time, I want to touch briefly on SBA loan program. And I encourage members to visit APMA's website, as we have 2 webinars on economic relief resources, with one of those dedicated just to PPP, and a video and podcast on applying for these loans, as well as FAQs. With additional funding provided by Congress, the SBA resumed accepting Paycheck Protection Program applications from lenders on Monday, April 27th. SBA resumed processing idle loans and advanced applications that are already in the queue on a first-come, first-served basis. It is our understanding that SBA is not accepting additional idle loans. As far as the PPP loans, we know there are a lot of questions about applying for a loan, And we've heard that banks, especially community banks, have started to accept applications from new customers. However, funds are distributed on a first-come, first-served basis. We received a lot of questions about the 8-week period when that begins, and it begins when the loan is distributed to the borrower, meaning when you receive it in your account. Another common question is how do self-employed individuals account their income? And SBA has said income is determined by the gains on your Schedule C up to $100,000. Another question we get is about loan forgiveness. And APMA has reached out to SBA and urged them to issue more guidance, and we've been told that guidance is coming shortly. So we have a little bit of time for Q&A, so I want to turn it over back to Dr. Tower for some questions.
Thank you, Ben, Dr. Lehrman, Chad. We have a few minutes for Q&A, but before our first question, I'll note that the link to today's evaluation, the survey, has been shared in the questions box in the GoToWebinar toolbar and will also be shared with you via email. You must complete the evaluation in order to be eligible for CECH. You will have through May 10th to complete the evaluation for this webinar, and certificates will be sent via email to the address you used to register for today's event within 2 to 3 weeks of today's webinar. We do have a few questions, so we'll get to those since we do have a few minutes left. A number of these are around some of the non-face-to-face services, so I'll try to group those together. The first is, can we initiate the non-face-to-face communication?
So it depends on which one, and that's why I spent so much time saying it, different rules for different services. To state it briefly, for Medicare, for telehealth, the first one, the answer is yes, we can initiate that. For the other 3 that were listed there for Medicare, all 3 of those for Medicare must be patient initiated.
Great, thank you. Can you get patients' information through regular emails during this health crisis?
Chad, I'm going to, as the attorney here, I'm going to ask for your blessing on my answer to this one. With what we read from the Office of Civil Rights about providing those services in good faith, I would be comfortable doing what was asked, obtaining that information over regular email. Chad, do you agree with that?
Yeah, I think if you can try and get it through more secure mechanisms, try that first. I mean, OCR has said they're not going to necessarily audit people, but they still could provide some oversight. So our recommendation, try first, to try some HIPAA or other secure mechanisms.
Great. Someone asked, I understand we have 8 weeks to receive forgiveness on certain bills like rent, paychecks, health insurance, etc. Do the checks have to clear within the 8 weeks or just need to be written during the 8-week window?
So the issue is the 8-week period is when funds are reimbursed. So I think if it's, as long as you, attempt to make the payment during that period, that should be okay, but we recommend talking to your accountant to confirm how you run your business finances.
Great. There are a few questions here about how you receive credit. There is a link to the post-event evaluation in the toolbar, but that information will also go out to you as an attendee after the event, so be on the lookout for an email from us with that link if you're having trouble finding it in the toolbar. Let's see. I was told by my DPM employer that my salary could not be counted for the payroll protection program because it was over $100,000 and was thus automatically disqualified. Is that true?
So it's $100,000 is the cap. So anything below is covered. So it's the 8 weeks. So you would take the 8-week period of $100,000. And so that would be eligible for the loan and loan forgiveness. Anything above $100,000 would not be.
Great. It was stated that the second distribution of the HHS was intended for practices to provide services to Medicaid patients or Medicare Advantage. If we used our Medicare number, will this be okay?
So to clarify, the second tranche was used to account for providers who don't have a lot of Medicare business. So those who may do more Medicare fee-for-service business, who may do Medicaid or Medicare Advantage. So that's the key. Using the so you're still going to be based on your Medicare. I think it's your billing and TIN. So what you apply for, using that information. Does that clarify it? I think. Yeah.
Great. We'll follow up here with one last question before we close out for today. Is there a form that you need to put in a telehealth patient's file? Something like a form to allow and agree for telehealth or telephone services, but since they can't sign it or fill it out, how do you handle that?
We suggest a consent be obtained that pertains to the non-face-to-face service that you're providing. I would also suggest documenting in that progress note. I made a template myself that's going in every note why we are providing the service non-face-to-face and what's going on currently that has led us to trying to keep them home. And yes, the consent is very nice, but if they're not there to sign it, you can't get them to sign it. That can be obtained verbally and document consent was read to the patient. They agree to, whatever needs to be there and document that you obtain that verbally. Always safe to check with your risk management provider to see if they are comfortable with what I just suggested. That's what we're doing.
Great, thank you. I want to thank our panelists today and thank you all for joining us for week 1 of the APMA Online CECH series. We hope you'll join us next Thursday, May 7th at 3 o'clock Eastern Time as Dr. Tracy Blahovic reviews dermatologic manifestations of viral diseases, including those recently associated with COVID-19. Check out www.apma.org/online CECH for the most up-to-date details about the series. Thank you all and have a great day.